This is a case of a 72-year-old man who presented initially to an outside ED, respiratory failure, was intubated there, had really had some symptoms for a while, so probably in retrospect had been drifting into heart failure for a while, so it was a presentation more of decompensated heart failure than it was of acute MI. He was transferred to our facility and actually accepted into our medical ICU initially, and then cardiology got involved. You see there his past medical history. He really wasn't on a lot of medications. When we first encountered him, he was normotensive but tachycardic. He was still intubated and still had some fluid on his lungs, and you can see there his lab work, diabetic with a high glucose, really a very minimally elevated troponin of 2 and a mild degree of renal insufficiency. So, of course, we suspected that he probably would have multivessel coronary disease. He was taken to our cath lab, and you can kind of hear the collective groan in the control room when we took our first shot, and looks like he's got both an occluded LAD as well as an occluded circumflex. His right coronary artery has a kind of an intermediate mid-stenosis and well collateralizes both of the left coronary vessels. Here's another view of that, showing the LAD. Showing these really to be very fine targets, and although the diagnostic physician didn't do dual access and contralateral injections, we'll show some pictures of that in a minute, and the value of that. I know we'll talk about that more in the CTO sections tomorrow. You got the idea from the pictures here that these occlusions weren't necessarily that long, even though they were complete. Okay, so there we are, ugly picture of the left, lots of collateralization. So he went back to the ICU, had kind of a long course. We did get CT surgery involved, as you would expect, as a heart team, and they were concerned about whether the patient was a good candidate and whether he would survive, and they really wanted to ask the question of how much benefit might he accrue from this, and so they asked for some viability testing. We did that. That wasn't good enough. They want another viability testing. So anyway, we ended up getting a nuclear study which showed actually most of the basal and mid-anterior and anterior septum seemed to be reversible. Only the apex seemed to be not reversible. We got an MRI at their request and really showed similar findings. Importantly, we saw that there was no apical thrombus, so that was nice. After all of that was said, even though there was really a fair amount of reversibility, they declined him for surgery. So kind of like we said earlier, we kind of kicked it down the road. And so we felt like this is something that we could take on as at least an option, try to open up some of his left-sided vessels. So because he did have high risk for surgery, reduced LV systolic function, we did want to use mechanical support, as has been demonstrated in other cases this evening. This is an Impella CP device, which has really become our go-to percutaneous VAD. And, you know, we can discuss that more, but we've used the 2.5 for a long time, and there are just many instances where you feel like that's not adequate. It's not enough support, and so granted, there's not an abundance of data on CP compared to anything else, but we'll always take a little more support, won't we, than a little bit less. So as you can see here, our approach, I just wanted to demonstrate that to you. We put the Impella in from one groin, the left groin. We used the right groin for what will ultimately be our left main guide, which is a EBU guide. It's a 7 French. And then we use right radial access as for a guide for the right coronary artery, mostly just to visualize the left, but we were also prepared to go retrograde if that's what we needed to do. So here we have 2 injections simultaneously, and I think you can begin to see, well, we learned a lot of things. Number one, we learned that LAD might not even be completely occluded. That was a surprise. And number 2, as we'll see here in some other pictures, the occlusion in the circumflex, while complete, was, as we kind of suspected, quite short. So here we go, kind of a couple of pictures there, areocaudal on the right, and again you can see that circumflex occlusion does appear fairly short, and the LAD might even be a subtotal occlusion. So that was a gift. So we started with the LAD, and kind of in a typical CTO approach, we actually will usually begin with either a workhorse wire or a filter XT or something just to probe in case there are channels there or it is subtotally occluded. And in fact, the workhorse wire went right down, indicating that was actually not a complete occlusion. actually wired out into the diagonal there using a Corsair support. Ran the Corsair down, exchanged, well, we didn't exchange our wire because that was a workhorse wire. Did a little balloon, and that's what we saw, and that's after stenting, so we were very pleased with the LAD, and so we moved on to the circumflex. Circumflex, in addition to being a short occlusion, seems to have a little beak, so it has lots of favorable features to it. So we came down, again, here it is with the retrograde injection, so we could see exactly where we were going. Our approach here was, again, kind of wire escalation, workhorse wire, Fielder XT. Those didn't go, not surprisingly. So at this point, we actually went straight to a Confianza Pro 12 with the idea that we had a very good feel for where we needed to go. So since we knew where we wanted to go, the Confianza Pro 12, it's a very stiff wire, but it's a very, very controllable wire, and one where if you know where you need to put it, you can typically put it right there. So we went there next, kind of probing. Okay, so we've made a little bit of advancement down really to the end of the occlusion. We're hoping we're in the lumen or we're about to re-enter. It looks very favorable, and then you take multiple views and you realize we're actually subintimal at this point. So we brought the wire back to about where the other branch is, and again, made another pass. This time we came down on the left side of the vessel, but unfortunately continued to be subintimal. Sort of have a decision, and I don't think we have time to really open this up, but our thinking was, do we continue to try an integrate approach in which we're going to have to essentially do luminal re-entry of some sort, either with a wire or with a device, or is this a case where actually a retrograde approach would be desirable? What we decided to do was to try an integrated re-entry technique using a Stingray balloon. And part of the reason for my thinking about that is that we had a very long segment. You'd hate to get in after a branch point, or you're likely to lose that branch. In this case, both of the distal obtuse marginal branches appeared roughly equal in size, so there wasn't necessarily one we wanted to lose or only one we wanted to gain. So our goal was, if we could re-enter the lumen where my arrow is there, if we could re-enter the lumen about there, then we can stand it on back and we wouldn't lose anything distally. So what you see on the right-hand screen, you see the two little dots from the Stingray balloon. We've positioned that just proximal to that distal bifurcation. And although this is a device that I think takes some practice and takes some technical expertise, I am not an expert at it, but we have had some successes and we've had some failures with it. And fortunately, we were able to get back in the true lumen rather quickly here. This is actually the Stingray wire. Distally, we thought we were in, but we had thought that before, so we actually brought the Corsair catheter, aspirated it, we could get blood. We thought we were in the right place, took a little angiogram here to prove it, and then exchanged our wires. And then two stents, one starting just before the bifurcation, and then another one up in the mid-vessel, and that was sort of our final results right there. And just as described by the previous speaker, we went ahead and we had pre-closed the Impella device, so we removed the Impella at the end of the case. The patient tolerated it well. From a hemodynamic perspective, we were able to close that device, and he did very well. I wish I could give you a little more follow-up. It's only been a couple of months since then, so we sent him home with a life vest, and he continues to follow up, and we'll have further reassessment of his LV function in the very near future. Thank you very much.